Good afternoon, everyone. It's 3 o'clock. Let's start the session. So welcome to the Jaipur Surgical School. This is actually an extension of the Jaipur Surgical Tutorial, which we have been running for last more than 3 years after I shifted from SGPGI Lucknow to Mahatma Gandhi Medical College and Hospital in Jaipur. And the Jaipur Surgical Tutorial is actually managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery with me here. And the Jaipur Surgical School is being managed by Dr. Piyush Vashne, who's at AIMS Jodhpur, again, my former fellow from SGPGI. This Friday afternoon activity, we actually started on a special request by colleagues from Africa, and because they were not able to attend the Saturday morning sessions. Unfortunately, the live attendance at these meetings is very small. But what we have observed that when these recorded videos are uploaded on the YouTube by my colleague, Dr. Avinash Tank and his team at Dwarika Hospital in Ahmedabad, we get a good number of views. So my only request and plea to all the faculty is not to get disheartened by the small live attendance at these sessions. Your effort is not going waste because a large number of students and surgeons are watching your presentations later on the YouTube. So for today's session, we have a guest faculty, Dr. Vineet Vakade, who's working currently at the Ashwini Hospital as a consultant GI surgeon in Sholapur in Maharashtra. And he has been recommended by one of the very senior members of surgical gastroenterology community in India, Dr. S.K. Mathur. And he's going to talk to us about very dangerous, although not very common, but we are seeing more and more cases in the post-COVID era. I hope Dr. Vineet will touch on that also, that why we are seeing so many cases now after COVID. That is mesenteric ischemia. So with that, I welcome Dr. Vakade to the online education portal, Jaipur Surgical School, and request him to make his presentation. I also welcome my colleague, Dr. Rajendra Desai, one of the regular faculty members at the Jaipur Surgical Tutorial and Jaipur Surgical School. Dr. Vineet, please.
At the outset, thank you very much, Professor V.K. Kapoor, sir, for having me here. And it is really humbling to talk here all in front of you, who have been all our teachers for so many years and continue to teach us. So thank you very much, and please excuse me for any errors or omissions from my side. So today, as sir said, we'll be touching on a very important topic, that is acute mesenteric ischemia. We are seeing a lot of these cases, unfortunately, in our neck of the woods. The reasons we'll go through as we progress. So today, what we'll be discussing today is symptomatology, workup, medical management, revascularization strategies, surgical management, our personal series, which has almost now around more than 190 patients over the past 11 years. And we'll focus more on practical aspects and lessons learned rather than pure theoretical things. So it all started when Professor S.K. Mathur gave me this topic for my dissertation during DNB surgical gastroenterology, and somehow these patients had this topic stuck with me for during my consultant career as well. So a bit of theory to start with for the benefit of the postgraduates. Acute mesenteric ischemia is defined as an abrupt reduction in blood flow to the intestinal circulation of a sufficient magnitude so as to compromise the metabolic requirements of the organ. Despite growing awareness, sorry to say, especially in our part of the country, in a tier 3 city, there's a lack of awareness about this entity, and hence there's a lot of delay in getting appropriate treatment, leading to a lot of morbidity and mortality, as we'll discuss subsequently. So clearly, optimizing patient outcome is intimately dependent on a high index of clinical suspicion, early and aggressive evaluation and investigation with these patients, and a very expeditious therapeutic intervention. It's worthwhile to remember that most of the series in India report the incidence of acute mesenteric ischemia to be at least a decade earlier as compared to Western literature. And at the end of the talk, when we discuss our patients and our data, you'll come to know that it happens much earlier in our country. And the problem is it happens to patients who are in the peak of their lives. And it has got a great emotional as well as economical burden. as we all know, there are no clearly defined treatment guidelines. Very difficult to establish level 1 evidence in these kind of diseases. So we have to go by our experience and some of the guidelines which have been given. Now, again, for the benefit of the postgraduates, just a overview of the mesenteric vascular anatomy and physiology from a applied anatomy point of view. The SMA is the primary blood supply of most of the small bowel. One has to remember almost 90% of the small bowel and part of the large bowel is supplied by the SMA, with some collaterals from the celiac artery and the IMA. The splanchnic circulation receives around 15 to 35% of the cardiac output, but one has to remember the oxygen extraction by the bowel is relatively low, especially in fasting state. So most of the oxygen will be still carried to the portal vein to the liver. The blood supply must be reduced by more than 50% before the intestine shows any signs of ischemia, and consequently the small intestine is able to compensate for a more than 75% reduction of blood flow for up to 12 hours. Now, this fact is very important, as we'll come to know when we discuss the revascularization strategies for these patients. Now, coming to the etiology, acute mesenteric ischemia obviously can be arterial, can be venous. If it's arterial, it can be embolic, it can be thrombotic, it can be non-occlusive mesenteric ischemia or NOMI, or it can be a mesenteric venous thrombosis. Now, let's discuss one by one. Acute mesenteric arterial embolism constitutes more than 50% of the cases in most of the series, especially in our series as well. Most common origin of the embolus is the left atrium. Most commonly, these patients either will have a atrial fibrillation or a prior history of myocardial infarction with poor ejection fraction leading to formation of clots within the ventricles. In our city, at least, or in our district, rheumatic valvular heart disease is very common. So most of these patients will have a rheumatic valvular heart disease and resultant either a MS or AS. SMA is particularly vulnerable. One has to understand, if we pay attention to the anatomy, the SMA is a relatively large diameter vessel and it has a low takeoff angle from the aorta. So if the embolus enters the aorta, because all other vessels predominantly originate at 90 degrees, especially the renal vessels, celiac, they are relatively spared, but the SMA being a direct branch and a branch with a low takeoff angle, the embolus can easily go into the SMA. Majority of the emboli will lodge 3 to 10 centimeters distal to the origin of the SMA. This is very important for us from a surgeon point of view, because even if there's a massive thrombus of the SMA, still the proximal jejunum will be spared. That is very important from a long-term perspective. Now, if you see these patients in arterial embolism, the good thing is that because it's a sudden reduction in blood supply, there's no time for formation of collaterals. Because there's no time for formation of collaterals, the gut undergoes ischemia very fast and very soon. And so you have a very, very clear-cut line of demarcation in these patients. As vis-a-vis, we'll see in patients with thrombosis, the line of demarcation will be not very clear-cut. So in acute mesenteric arterial thrombosis, 25% of the cases are due to mesenteric arterial thrombosis. They are associated with pre-existing chronic atherosclerotic disease leading to stenosis. Thrombosis usually occurs at the origin of the visceral arteries, and symptomatic SMA thrombosis most often accompanies a celiac occlusion. And as sir rightly said, in our series also, prior COVID infection has been known to be a very important risk factor for the development of mesenteric arterial thrombosis. For some reason, as we all know, it predisposes to myocardial infarction, strokes. Similarly, we have seen, and we had presented this series in Massicon 2021, which when we are at the peak of the second wave, we got a lot of cases of acute mesenteric ischemia in COVID-19 patients, and that time we had presented a series of 9 cases who had active COVID disease or just who had come out of COVID disease and who had this acute mesenteric ischemia. So yes, the COVID does predispose to mesenteric ischemia, and that is very, very well known fact. Now, how to distinguish clinically? So intraoperatively, when you open these patients who have a thrombosis vis-a-vis embolism, these patients, because it's a slow growing process, there is an attempt to the body by the body at formation of collaterals. So you can see this kind of picture. So there is an attempt at collateralization. So the line of demarcation is not very clear. So we'll have a part of the intestine which is absolutely gangrenous. You will have a zone which is kind of a gray zone where the body has attempted revascularization, and you will have an apparently normal bowel. So the line of demarcation is not very defined, and you can actually see a lot of mesenteric collaterals during laparotomy in these patients. Relatively, they have a better outcome. Now, non-occlusive mesenteric ischemia is an increasing entity. Most of the series will report 20% cases of NOMI. However, in our series, the percentage is much lower because very difficult to actually define and diagnose NOMI confidently. So, it's basically a consequence of severe vasoconstriction of the splanchnic circulation, maybe due to low splanchnic blood flow, maybe due to diversion of the blood flow from the splanchnic circulation to the rest of the vital organs. So, most commonly involved is the ileocholic artery. Usually in our setup, what we see, because we don't have very good intensivists or our ICUs are mostly managed by non-allopathic doctors, they tend to give a lot of vasopressor agents in patients who are hypovolemic. Simple thing they don't understand is first give fluid resuscitation and then add vasopressors. But if you give vasopressors without adequate fluid resuscitation, that is the hypovolemic patients, they cause severe mesenteric vasoconstriction, and these patients, especially if they are using vasopressin as a vasoconstrictor agent, actually develop non-occlusive mesenteric ischemia. Now you can see this patient, you have put it in the example, this patient had undergone a LSCS, was given double dose of methergine for PPH, and you can see this is the cecum which is completely necrosed and perforated. So again, the vessels on CT scan were normal, but probably because lot of vasopressor agents were given this patient, she developed a spasm of the ileocholic vessel, and that led to necrosis and gangrene and perforation of the cecum. So these are the cases which we occasionally see post NOMI having a thrombosis where the main vessels are actually normal. Again, this is one more patient we saw, pregnancy with acute myocardial infarction, 12 weeks amenorrhea, on patient present with severe abdominal pain. USG, as usual, they reported something non-specific, but the patient was not settling, tenderness guarding everywhere. So we decided to put in a scope, and when you put in a scope, this patient had severe ileal gangrene. And again, this patient had undergone multiple hormonal manipulations in the past for infertility. So this patient underwent a right hemicolectomy and continues with the pregnancy. Now, mesenteric venous thrombosis, again in our series, we see a lot of mesenteric venous thrombosis, much more than what is reported in international literature, that is around 10%. We see around 20%. So classically for the postgraduates, again, mesenteric venous thrombosis is usually a function of the Virchow trials, that is stagnated blood flow, hypercoagulability, and vascular inflammation. Hypercoagulability again may be due to some inherited disease as well. And there's a laundry list of investigations, protein CES, antithrombin 3, all those factor V Leiden mutations. We will discuss subsequent slides how to go about doing a hypercoagulable workup. Is it necessary in all the patients? Is it practical in all the patients? That we shall come to know once we actually go ahead and discuss these things in the subsequent slides. Now, very peculiar to our neck of the woods. We live in a very hot climate, especially in Solapur where I live. Today as we speak, the outside temperature is 43 degrees centigrade, and dehydration is a very, very common factor in patients with mesenteric venous thrombosis. Second thing what we have observed, and we are observing now at present, is prolonged fasting, especially when Ramzan comes in summer months. Ramzan, as we all know, gets preponed by around 15 days every year. So when Ramzan comes in the peak of summer, we see a lot of these patients coming in with mesenteric venous thrombosis. Again, due to prolonged fasting, they don't drink any water throughout the day, keep on working in the fields with such hot sun. And so these patients tend to have they tend to develop a lot of mesenteric venous thrombosis. Other very peculiar factor which we have observed in our part is use of over-the-counter OCPs. Now, there's a belief in here that a lady should not have her periods during festivities, maybe Diwali, maybe Ganpati festival, any festival. So they tend to take some OCPs from the pharmacy directly to prolong or delay their periods, and these high dose maybe estrogen contraceptives are also responsible for development of mesenteric venous thrombosis. Other factor very important, which is often overlooked, is post-splenectomy thrombocytosis. You have had one patient whom we have done a splenectomy for trauma, and then patient developed a continuously increasing platelet count, and they develop post-splenectomy thrombocytosis. That leads to thrombosis of the splenic vein, that leads to thrombosis of the superior mesenteric vein and superior mesenteric and portal venous axis. So now we have routinely started monitoring platelet counts in these patients every 3, 4, 5 days, and moment the platelet count goes above 5 lakh, we start them on high dose aspirin. It goes above 7 lakhs, we start them on aspirin plus clopidogrel. Above 10 lakhs, we give hydroxyurea. So again, this post splenectomy thrombocytosis is again an important factor for development of venous ischemia. Now, venous ischemic typical bowel tends to be a very dark colored maroon bowel, extremely congested because the arterial flow continues and there is no venous drainage. So it's a lot of congested bowel. The rest of the bowel also is slightly congested. So you will not find a very clear cut line of demarcation in these patients. So again, in these patients, it's very difficult to decide where you would end your resection and where you would anastomose. Now, coming to the symptomatology, severe abdominal pain out of proportion to physical examination is classically described as the classical finding of acute mesenteric ischemia. It has a recommendation 1B. If the physical examination demonstrates signs of peritonitis, there is likely to be irreversible intestinal ischemia with bowel necrosis. That is common knowledge. In our series, 95% of the patients presented with abdominal pain, 44% present with nausea, 35% with vomiting, and 35% with bloody diarrhea, and 16% with blood in rectum. Delayed presentation, of course, patients coming in late will present with septic shock and severe lactic acidosis. Most of the time, the acidosis will be refractory to any treatment. Now, this is just a chart summarizing the etiopathogenesis. Now, I think the incidence of NOMI is actually increasing quite a lot, especially as our intensivists get more and more aggressive in managing these patients. So the incidence of non-occlusive ischemia is increasing, as well as the incidence of venous thrombosis as well, especially with hormonal replacement therapy and all those things coming into our repertoire. Now, patients with mesenteric arterial thrombosis often give a history of chronic abdominal pain. Chronic mesenteric ischemia we will not discuss today because it's a completely different topic. Patients with non-occlusive mesenteric ischemia will have a pain that is very non-specific, very diffuse, and generally they will have some other very bad condition like poor cardiac output, congestive cardiac failure, dilated cardiomyopathy, so on and so forth. Patients with mesenteric venous thrombosis present with a mixture of nausea, vomiting, diarrhea, abdominal pain, and most of the times these patients will have some kind of a GI bleed due to associated portal hypertension. Nearly 50% of the patients with embolic MI will have a atrial fibrillation or some kind of a predisposing factor prior to that. So investigation wise, I think we'll not go into details. Routine investigations are sufficient. Very important to actually do a ABG. ABG should done in all patients of suspected ischemia. You should look at the level of metabolic acidosis because at times the appearance of the patients is deceptive. They may look well, but if they are really badly acidotic, the patient may suddenly die of cardiac arrest. Elevated lactate is again a very good marker for gut necrosis, and if you kind of do serial lactates, and if the lactate levels are increasing, then you have to be very careful, maybe open these patients up to look for gangrene. In our study, we are doing serum LDH from time back, and LDH of more than 2000 was very sensitive for these patients for gut necrosis. Now, what is the workup for hypercoagulable states? Yes, there's a laundry list of workup. You do a protein C, S, antithrombin 3 activity, prothrombin gene mutation, anti-phospholipid antibody, anti-cardiolipin antibodies, APLA-ACLA, factor V Leiden mutations, JAK2 mutation, and homocysteine levels. Now, one has to remember that protein CS and antithrombin 3 has to be sent before you give heparin. Once you give heparin, you can't send this test because their reports will be erroneous. Whether it is practical to do all this workup. Now, yes, if you are in a very resource-rich place, yes, ideally you should do this workup for all the patients who are presenting with thrombosis. But people who are working in setups like me, where this workup at least costs 25,000 rupees for our patients, it's a big amount. So what we do, our policy is in patients who are young, who develop thrombosis at less than 40 years of age, who have no other precipitating factors, no other history. In patients who have recurrent thrombosis, previously has been admitted with some MI, previously has been admitted with cerebral problems, so on and so forth. And patients who have a family history of such thrombosis, in these patients, we end up doing this hypercoagulable state workup. Otherwise, we don't do this workup. We'll discuss that subsequently when we discuss our results. Now, radiologically, how do we investigate these patients? CT abdomen with contrast is the best investigation and has to be done immediately. There's a recommendation 1A. Now, as we already have seen in the introduction, delay in diagnosis is a dominant factor that accounts for the continued mortality. So one has to do a CT scan very early. The CT scan should have basically all three phases: arterial, venous, and delayed venous, and of course should have the facility of multiplanar reconstruction. It should be at least a 64, but ideally a 128 slice scanner, because you want a very clear-cut arterial, venous, and delayed venous phase. The scanner has to be fast enough to take all the three phases. In peripheries, many of the time these type of scanners are not available. Adequate IV contrast is very important. We insist on at least 1 ml per kg of IV contrast. If the patient is hypotensive, then remember the CT scan person has to adjust the phase timings as per the BP. So if the hypotension, then the difference between arterial and venous phase has to be more, otherwise your vein evaluation will not be appropriate. And one very important thing is that many of the physicians will not allow you to do a CT scan saying that the creatinine is raised and everything. But remember, delay in diagnosis, misdiagnosis are far more detrimental to the kidneys. So with due consent, I think if it, as a life-saving procedure, if mesenteric ischemia is strongly suspected, even if the creatinine is raised, I think one should go ahead and do a contrast CT in the interest of diagnosis. And needless to say, for the postgraduates, I think it is very important that what our teachers have taught us: always go to the console and see the CT scans yourself, because the radiologist may actually miss some distal thrombosis, especially in the terminal most branches of the ileocolic. It's often missed by the radiologist. Now, findings and percentage from our own study, we could demonstrate thrombus in 100% of the patients. 50% we could demonstrate nematosis intestinalis, that is air in the bowel wall. Almost 75% patients we could demonstrate bowel wall edema, especially in venous thrombosis. Free fluid is there in 40% of the patients. If you see the CT very closely, you will have a poor mucosal enhancement, especially in arterial thrombosis, and of course 20% will present with free gas, that is a delay. Now, there are certain CT findings which are very bad. Portal or mesenteric venous gas, if you see, it is a very, very poor prognostic sign and suggests massive bowel infarction. Non-occlusive mesenteric ischemia, unfortunately, has no classical radiological pictures, but you can see pruning of the peripheral mesenteric radicals on a good quality CT scan. Some people have described it as a Christmas tree appearance on a mesenteric angiogram, and that is very much suggestive of mesenteric venous thrombosis. So when the diagnosis of acute mesenteric ischemia is made, the first thing you have to do is fluid resuscitate the patient immediately to enhance the organ perfusion. Electrolyte abnormalities present should be corrected, should put an nasogastric tube and start nasogastric decompression. Now, often it is described the 3 R's of initial management. First is rapid diagnosis, which we have seen. We do an early contrast CT scan. Second thing is resuscitation. You have to resuscitate these patients very well. So first thing is, what are the goals of resuscitation? So you establish good tissue perfusion, because you need to have oxygen which is reaching the tissues. You need to give oxygen supplementation. Now remember, because the blood flow is limited, your partial pressure of oxygen in the tissues in the blood has to be higher for optimal oxygen delivery to the end organ. So even if your SpO2 is normal, be very careful so as to give higher percentage of oxygen, so that your end organ perfusion, the end organ oxygenation is good, and that prevents lactic acidosis. Always insist on broad spectrum antibiotics depending on the institutional protocol. Initiate anticoagulation. How to do that we'll see in the subsequent slides. And avoid excessive vasopressors, because excessive vasopressors, again, we have seen actually cause reduction in mesenteric blood flow and should be avoided. Now the question always arises whether to use conventional heparin or low molecular heparin. Here I have put both the advantages and disadvantages. For conventional heparin, the advantage is it is cheap, easily available, easy to monitor, easy to reverse with vitamin K. Suppose tomorrow you decide to operate these patients, it is very easy to reverse these patients with vitamin K and protamine, and it is not dependent on any absorption because you give it IV. The disadvantages of conventional heparin being it may induce platelet factor 4 antibodies and result in platelet dysfunction, which may trouble you during surgery, and it requires frequent APDT monitoring. Ideally 6 hourly. In our setup, we do it 12 hourly. Now, what are the advantages of low molecular heparin? It is easy to administer. You give a subcutaneous dose, you have a pre-filled syringe, no infusion pumps are required, no monitoring is required, but it has got significant disadvantages. The disadvantages being absorption is unpredictable. If you have a patient who is very edematous, the absorption of your subcutaneous injection may not be adequate. if you have a patient who has got profound peripheral vasoconstriction due to hypotension, due to inotropes, you will have a very poor absorption. You cannot monitor his activity factor. Activated factor 10 levels are not available in most setups, at least not available in our setup. And it is very long acting. So it is impossible to reverse. If you decide for emergency surgery, it is impossible to reverse these patients. So our choice is conventional heparin. Our protocol is we give 80 units per kg bolus, end up giving around 5,000 units bolus, followed by infusion at 18 to 20 units per kg per hour. We try to keep the APTT about 2 times the control value and do a 12-hourly APTT assessment. Now, what about the surgical management? So once you are done with rapid diagnosis, resuscitation, revascularization, now the next important thing is to go ahead with resection of the ischemic bowel, do a relook laparotomy if required, and restoration of the continuity of GI tract whenever it is practical, because most of the patients will end up doing some kind of stomas or diversions. Now, what are the principles of surgeries? Prompt treatment should be done in patients with overt peritonitis, that goes without saying. Now, what are the goals of surgical intervention? First and foremost is to re-establish the blood supply to the ischemic bowel. It is very easy in theory to say, it's very difficult in practice, because most of the patients will present late. It's very difficult to reach the SMA to do a thrombectomy surgically. So it is difficult in practice with very poor results. We have done it just once and results were not good. Hence, it is not very frequently attempted. Second most important thing is to resect all the non-viable bowel. Third thing is to preserve all the viable bowel, which is very important, as we'll discuss subsequently. Now, this is one patient we had attempted a mesenteric thrombectomy. This was the SMA we exposed. We did a thrombectomy from the SMA. We thought that it was a good thrombectomy, good establishment of blood flow. But again, 4 or 5 days later, we ended up opening this patient up with a massive gangrene. So again, rethrombosis is very common in these patients. So it's very difficult to do a SMA thrombectomy, and at least in my practice, we don't do it frequently. Now, damage control surgery, what it is described classically in textbooks, is basically you for patients who require intestinal resection, you assess the bowel viability and then you plan for a laparotomy. Now, relook laparotomy is again very important aspect in these patients, because there is a certain subsequent of patients, at least 10 to 15%, who will have repeated gangrenes. So this is one patient on the left side who was reopened for a repeated gangrene. Patient was not doing well, had leaked. So we thought that maybe some other part is gangrenous, and we reopened and we found more intestine which had already become gangrenous. Again, these patients, it's very difficult to close these patients. So our preferred way of closing nowadays is a VAC. We do a laparostoma with a vacuum assisted closure. So once you have a vacuum assisted closure, it becomes very easy for a second look, third look. Now these patients, we had to undergo a relook for more gangrene. Then again a third relook, because the patient had persistent intra-abdominal collections and pus discharge. And then with subsequent VAC applications and all, we could achieve final closure in these patients after 6 weeks. So again, in these patients whom relook laparotomies are required, I think vacuum assisted closure is a very good technique, or a very good device which is available at most of the places, very cheap, and it is used with good results. Now, endovascular revascularization is often talked about in these patients. And yes, if the patient has presented very early to you, maybe in the first 6 hours, 12 hours, it is a worthwhile technique. However, it has got issues, especially in tier 3 cities. The availability of expertise, an interventional radiologist who is willing to do a thrombectomy and a stenting, is scarce. It is expensive. It is a very narrow window of opportunity, as I said, a few hours. It has got very unpredictable results, as we'll show you subsequently. And of course, reperfusion injury is a big problem in these patients. Okay, patients actually become worse after you do a stenting. Now, this is a patient who had got a proximal SMA thrombosis, as you can see, a narrowing. You can see here, this is the interventional radiology. The vessel has been opened up and a stent has been deployed. But however, this patient continued to do not well. So we opened this patient and we saw that the segment of bowel was gangrenous despite revascularization. Now, the way to look at it is whether your glass is half full or half empty. Now, the way I look at it is, if you see this patient had a proximal SMA, would have massive bowel gangrene and probably lost all the bowel. After doing some revascularization procedures, after doing stenting, at least it has limited the area of gangrene. So in my view, at least it serves the purpose that it limits the bowel involvement, so that massive or a catastrophic resection in these patients can be avoided, and they can be managed with a limited resection. That is what my view is. But however, our experience in this area is very less because of the issues, as I said previously. Now, mesenteric venous thrombosis is a different ball game altogether. Basically, we treat more and more of these patients conservatively now with a continuous infusion of heparin. The recommendation is also very strong for this. Now, the biggest problem is when to operate in venous thrombosis. Why? Because clinical examination in these patients is very misleading. Many other times, we have all seen these patients have slight tachycardia. The abdomen seems to be slightly doughy, as we see in tuberculosis, slightly doughy abdomen, some tenderness here and there, but they are not worse as well. They don't become worse, they don't improve fast. So it is very difficult to decide in these patients whom to go ahead and operate and whom to just continue with heparin. Some red flag signs we have seen in our series is, when do we go ahead and operate? Patients who develop de novo fever, patients who were previously afebrile start suddenly spiking fever. Always suspect some gangrene or some perforation in these patients. Patients, as I said, who have an increasing lactate on ABG despite adequate resuscitation. You have adequately resuscitated, the CVP is good, the urine output is 1 ml per kg per hour. You do an ultrasound, the IVC is well filled, and still your lactates are going up and up. Again, this is a very bad sign. These patients, you go ahead and I think operate early. Third is persistent inability to tolerate oral diet. You give oral diet, patient starts vomiting, the pain increases in severity. Maybe the patient is developing a stricture or has a gangrenous segment. And you do repeated CT scans and they are showing localized collections. Localized collections in these patients are very bad signs. Probably that bowel has perforated. Now, in these are the patients, sometimes we see in this patient there was a venous thrombosis. You can see spontaneous intra-abdominal hemorrhage. Now, these patients, because of portal hypertension, sometimes they have ruptured collaterals in the abdomen, and these patients, one of these patients has presented with massive hemoperitoneum secondary to maybe a portal hypertension and ruptured collaterals. Now, in these patients, what we have learned is, in mesenteric venous thrombosis, use of terlipressin actually helps, because anybody who has operated these patients will realize that moment you open these patients, the moment you start handling the bowel and mesentery, everything starts oozing because of collaterals, because of pressure within the collaterals. Now you need something to bring the portal pressures down, and what we have seen is using 2 milligram terlipressin at the induction actually brings the portal pressures down, and it really helps in handling the bowel and anastomosis. So we had put this up as a poster in ISG 2018, and it was criticized because it was an observational study. We did not have any markers for reduction in portal pressures, and so it was just an observation that the blood, the bowel was easier to handle, the blood was lesser, but we could not actually document the portal pressures in these patients. But definitely we continue to do the same, because practically we feel that it makes bowel handling easier, it makes blood loss lesser. Now, sometimes in arterial thrombosis, you have this massive gut necrosis. Now, the classical line which is described in textbook is, finding of massive gut necrosis requires careful assessment of the patient's underlying comorbidities and advanced directives to judge whether the comfort carries the best treatment. What I interpret from this is, what we do is we call the patient's relatives in, we show them the bowels, we tell them that maybe he'll lose his entire gut, and if the patient is willing or affording for a small bowel transplant, we'll go ahead and resect whatever we can resect and send these patients up for a small bowel transplant if they are affording. If not, then I think comfort is the best treatment for these patients, because anyway they are not going to survive. Now there are some patients, just excuse me. Now there are some patients where we can do some bowel sparing surgeries, that is, who have massive ischemia but who have skip lesions in between. So what we can do is, we can resect the gangrenous bowel, and we can the bowel which is kind of marginal, we can leave it behind and do multiple anastomosis. Again, this is a very controversial thing. You can develop multiple leaks, but for these patients I think that is the best approach. Now, new kid on the block is ICG guided surgery. If you have ICG cameras, if you have ICG with you, then yes, and you can do ICG guided surgery, because that will give you an idea about the perfused bowel vis-a-vis non-perfused bowel. So as of now, we don't have it in our institute, so I don't have any experience with it. But yes, there are now case reports and there are series coming in with ICG guided surgery for mesenteric ischemia. That actually appears to be the future. Now, the last point of the talk is our data. Now, our data spans for 11 years and 2 months. It's a single institutional study. Now we have 195 cases. This is a little bit older. I have not put up not analyzed the next 6 cases. So the average is around 1.5 cases a month, which is low. I accept because it's a private hospital, single consultant. So we get the caseload is not very high, but still we get adequate number of cases. Now, as I said earlier, you can see the distribution between 30 and 40 and 41 and 50. Almost 50% of our patients are young patients who are, let's say, between 30 and 50 years of age, who have active working life responsibilities, are the earning members of their family, and hence this is a great catastrophe for the family, emotionally as well as financially. So very important to treat these patients very well because they are the breadwinners. Males are predominant, and this is the biggest problem in our setup. Patients come to us late. So hardly we have any patients who come in less than 12 hours. That is the golden period. Most of the patients will come after 96 hours, 80%, when the options for revascularization are extremely limited or practically no options for revascularization. Now, most of the common comorbid illnesses are diabetes. We have a higher rate of venous thrombosis than the literature. As I said earlier, literature says 10%. Venous thrombosis, 90% arterial. In our series, there are almost 22%. That is double of the international series. We don't know why. Most of the arterial thrombosis will be proximal SMA and distal SMA. So if you combine proximal and distal SMA, around 60 to 65% will be superior mesenteric arterial thrombosis, which is most common. Prothrombotic workup we have only done in around 20% of the cases, as I said earlier, because availability, financial issues and everything. But worthwhile to know that in patients whom we have done, JAK2 mutation and factor V Leiden mutations are very common in our setup. You can see almost 50-60% of the patients will have one of these two mutations. Now, the reason being, in our society where I lived, co-sanguineous marriage is a big problem. So most of the patients will have some degree of consanguinity, maybe grade 2, maybe second degree consanguineous marriage. Third thing is homocysteinemias are again very common. Around 13-14% of the patients will have hyperhomocysteinemias, and is the most easily treatable hypocoagulable state. Just vitamin B supplementation will cure these patients. So most of the patients were managed conservatively in our series. Around 59% and 41% underwent surgery. This is very interesting. Our overall anastomotic leak rates were around 17%. Mortality was 12.3% overall as a cohort of patients in 189. But in mortality in patients who leaked was around 42%. So once you have a leak, you have a 3 times increase in mortality. Now, late mortality, we are very poor in estimating that because again we have follow-up issues. Not of all patients will come for follow-up, so just 5% in our data, but it is grossly underestimated. I agree. Mortality in venous thrombosis who were conserved is nil. So none of the patients who actually received and successfully received conservative management did not have a mortality. However, leak in venous thrombosis who were operated was very high, that is 30%. If you recall previously, the leak rate was around 12%, but it more than doubles when we have patients of venous thrombosis whom we operate. That means that the patients of venous thrombosis whom we do anastomosis have a very high leak rate, possibly because of extremely edematous bowel. Mortality in venous thrombosis who leaked was as high as 60%, almost going up to 60%. So it is almost double of the patients of arterial thrombosis. Again, it goes to say that try and conserve as much of venous thrombosis as possible, because leak rates as well as mortality in these patients is extremely high. What we tend to do is we tend to do a clampless anastomosis and try to do a side-to-side anastomosis, again for the benefit of postgraduates, because the edges are the most ischemic, the curtains are the most ischemic. So you try to do a side-to-side anastomosis to do in a well-vascularized bowel. Again, judicious use of laparoscopy is something which we have learned. Suppose we feel that there may be gangrene, there may not be gangrene. So before you heparinize the patient, it is worthwhile to do a diagnostic laparoscopy and actually see the bowel. So if the bowel is gangrenous, you go ahead and resect at the same time. If the bowel is not gangrenous, you back out, remove the laparoscope, and you heparinize these patients. And we had presented the same at ISGCon 2015, which won an award at that time. And we continue to employ diagnostic laparoscopy in patients who are borderline and we feel that they may or may not have gangrene. So there's a last slide, respected chairpersons. Mesenteric ischemia requires a high index of suspicion, prompt and appropriate investigation. Very good quality CT scan is most important. Immediately a 3R and 6R policy, as we discussed. Most importantly, I think it requires a multidisciplinary approach and teamwork with physicians, anesthetists, surgeons in a tertiary care facility to give the best results to the patients. And of course, repeated counseling of patients regarding the guarded prognosis, prolonged ICU care, requirement of multiple surgical interventions possibly, and the high cost of treatment is, I think, very important. Thank you very much, respected chairpersons. Thank you.
Thank you. Thank you, Dr. Vineet. Rajen?
Yeah, very well presented. Thank you.
Thank you, sir.
Only two issues I had
Yes.
with the talk was you did not mention whether you put your patients on lifelong anticoagulation. I believe
Yes.
in doing that.
Yes, sir. We do
We put them
sir.
on warfarin.
Yes, sir. So I
Yeah.
didn't include that in because in the long-term follow-up. So what we do is, sir, for all arterial thrombosis patients, we'll give them aspirin clopidogrel for life. In patients who have venous thrombosis, we tend to put them on warfarin.
Yeah, same here. The other thing that I found was we had done a small study, not 190, but only 18 patients who had some form of thrombosis, cortical venous thrombosis, mesenteric venous thrombosis, or otherwise. Cortical venous was only 2 patients. Mesenteric venous thrombosis, we had 18 patients. And we found that 88% of these patients had protein C and protein S antithrombin 3 deficiency when the test was done 6 months after they recovered. At the time of ischemia, these tests often are erroneous because the levels will be reduced because of DIC. So I find that those who survive, we need to keep investigating them, finding out, and putting them on lifelong anticoagulation because they tend to come back with rethrombosis or they come back with EHPVO, and the EHPVO gets ignored. They come again with a picture of thrombosis, and then you lose them to variceal bleed. We lost one patient to variceal bleed because of previous EHPVO with bowel gangrene.
Yes, sir.
So, but I totally
Absolutely.
agree with your philosophy of not doing anything if they cannot afford a small bowel transplantation. It's a miserable death if you do a
Yes.
resection and anastomosis in them.
Right, sir. Thank you, sir. The same thing carrying forward regarding hypercoagulable workup, we do the same thing. Our hematologist actually they do investigate these patients once they are they have recovered, and I absolutely agree. Doing protein C antithrombin 3 during acute this thing gives erroneous results. That is absolutely correct, sir. That is the same. Our experience is the same.
So, the students who are watching and who are going to watch, a very important point which Dr. Vineet made during this last question discussion, arterial versus venous. Patients who have arterial vascular episode need to be put on antiplatelet drugs, that is aspirin and clopidogrel, like coronary artery disease. Whereas those who have had a venous vascular episode need to receive anticoagulation. So, Vineet, I'll have a couple of quick questions.
Right.
One is about post-plenectomy thrombocytosis. Is it transient or does it persist?
Sir, is it normally it is transient? Most of the patients, 90% it will be transient, but there is a certain subset of patients whom the platelet counts just keep on rising. So we do see it very not very routinely, but in very rare patients. One patient I remember had where platelet counts went up to 50 lakhs, and that patient actually required a platelet pheresis at the end of the day. But it is not very common, sir. I totally agree. It's a transient phenomena and is expected to come down in 2 to 3 weeks as the marrow kind of down regulates.
So, for the sake of students, could you please repeat the protocol again of
Yes, sir.
post-plenectomy
So what we
thrombocytosis?
do is, if the platelet count goes above 5 lakhs, we'll start them on aspirin. We'll start at 150 milligram once daily, not 75. We'll put at 150 milligram once daily. If the platelet count goes above 7 lakhs, we'll put them on clopidogrel plus aspirin. If they go on platelet count goes about 10 lakhs, we'll put them on hydroxyurea 300 milligram twice daily. If the platelet count continues to rise despite hydroxyurea, now we'll get the hematologist in, and if they go above 15 lakhs, 20 lakhs, then the hematologist actually they insist on platelet pheresis.
Okay.
Because again, they have a very high chances of retinal thrombosis, cerebral vascular accidents, and all those things.
My next question is, and maybe Rajendra also can respond to that after you reply. Suppose there is a young man who has no predisposing factor and he comes with either an arterial or a venous vascular episode. Now we know that this is a prothrombotic state. So irrespective of what you find on that expensive prothrombotic workup, probably this patient will need lifelong either antiplatelet drug medication or anticoagulation. So suppose you do a detailed, expensive prothrombotic workup and you don't find anything, would you not put the patient on antiplatelet or anticoagulation?
No, we'll definitely put, and that is the point, sir. That is why we don't investigate all these patients. In young patients, irrespective of the findings, we are going to keep them on anticoagulation. So
probably
that is one of,
it's just an
put
academic exercise.
Yes, sir, it's an academic exercise. I agree, but to an extent, we have to put a this thing label on what they are. Maybe in some patients, if they are really JAK2 positive, then siblings and all need to be tested to prevent these events and so on and so forth. So it has got some value, but yes, I totally agree. It may be skipped.
Okay, Rajen, you have any view on this?
Yeah. In young patients, we have always anticoagulated. But I have found that mesenteric venous thrombosis seems to affect people in the age group of 25 to 45, while arterial thrombosis tends to occur in patients who are above the age of 60 more often than not, as you would expect from atherosclerosis. And in an atherosclerotic thrombosis of the mesenteric artery, thrombectomy is of no use. You either do a thromboendarterectomy and reconstruct the vessel, or you do a bypass from the aorta and you recreate the bypass and use saphenous vein if the bowel is gangrenous, and if the bowel is not gangrenous, you use a graft. While if it is a embolic cause, you have found atrial fibrillation with a clot in the heart or a venous embolism, more often than not, an embolectomy will reduce the extent of thrombosis progressing. And these patients also need to be put on heparinization. My option is I put them on 25,000 units per 24 hours, 1,000 units per hour as an infusion. And I use heparin because it's cheap. And again, monitoring enoxaparin and dalteparin and all these conditions is very, very difficult. And in these subgroup of patients, we have observed a small subgroup where we have had the clotting progressing, and they tend to have what you call Hitch syndrome. And if they have Hitch syndrome, they present with DIC or with bowel thrombosis. And in those patients, we have changed them over to dalteparin or fragaparin.
So, Dr. Vineet, you said that unfractionated heparin we can easily reverse with protamine, and LM, the low molecular weight heparins, there is a problem. So suppose patient who is on low molecular weight heparin starts bleeding, or you have to do an intervention, does FFP help?
No, sir, because what happens is that the circulating LMWH will actually inactivate factor 7. So FFP will really not help. So it is again practically impossible to reverse these patients.
That's the most important problem with these.
Yeah. May I interrupt, sir?
Yes, please.
One of the things is that patients with unreversed anticoagulation is not a problem. Actually, on the blood value, you may get a APTT or a PT which is very high. But reversing it is a mistake. You should not reverse the anticoagulation. You should operate despite anticoagulation in mesenteric venous thrombosis. Because if you stop it and then you follow the principle of a post-operative anticoagulation follow-up, you tend to stop it for as long as a week, and it almost always extends. So literature at least mentions that you should continue anticoagulation while you're operating, and the anticoagulation you should use is heparin.
Vineet, can you please tell us again which are the situations where you would use a combination of interventional radiology and surgery?
Sir, yes, if the patient has one thing, if the patient has presented early, there are no obvious signs of peritonitis at the time of presentation. CT scan is not showing any pneumatosis intestinalis or any features of gangrene, mainly pneumatosis intestinalis. And in such patients, yes, who are relatively clinically stable, ABG is not showing lactic acidosis or not very bad acidosis. So in these patients, we'll actually go ahead and try for interventional radiology upfront and then observe these patients. But again, as sir said rightly, that yes, reperfusion injury is a problem. and you counsel the relatives that you may spend a lot of money on interventional radiology, but still at the end of the day you may require surgery as a salvage procedure. So that is something that should be clearly explained to the patient's relatives. And yes, it's a very important tool. I think revascularization actually limits the extent of bowel involvement and actually improves prognosis in these patients.
Do we know that what is the Indian experience on small bowel transplant? Has any of your patients had a small bowel transplant?
Yes, sir. Two of my patients have had small bowel transplants. Both have been done by Dr. Gaurav Chaubal in Mumbai and when he was in Pune. One for a patient, unfortunately, was a young boy who succumbed. One patient is doing very well. One patient is doing well. So only two patients of the entire series have undergone a small bowel transplant, both by Gaurav.
I think AV Science Group also is doing small bowel transplantations.
Mhm.
I don't have their numbers, but they are doing it.
So, in general, which patients do worse, arterial or venous?
Sir, in general, by and large, the prognosis, if we end up conserving venous thrombosis, as we most often do, they do well. Arterial thrombosis, if it is not a massive gangrene and if we operate, they do really well. The rate of rethrombosis, if we keep them on antiplatelets, is very low. Venous thrombosis will do well, but they'll keep on coming with some problem or the other. As sir said, sometimes they present with variceal bleed, sometimes they'll have some ascites, sometimes they will have some bowel distension, strictures, all these things. But by and large, they will keep on coming back to you. Arterial thrombosis, I think either they die or they do very well. That is what we have seen in our practice.
Thank you, Dr. Vineet. Thank you very much for a very extensive coverage of the topic and also your personal, very large experience with this rare and uncommon disorder. So maybe we will close this session and I'll keep you posted about, as I said that, for example, last week, last week, Dr. Puneet Dhar had talked about cystic tumors of pancreas. We had very few live attendance, but I just posted in the group that already in about 10 days time, we have had more than 150 views. So I think students and surgical colleagues are watching our videos, but probably at their own convenience. So with that, I thank you, Vineet, once again. Thank you very much. Thank you, Rajan.
Thank you very much, sir, for having me.
Thank you, sir.